Good morning.
Good morning.
Okay, it is working. All right, I'll go back on mute.
I think I need to see if we have at least, or I guess we could just do roll call. I think we can go ahead and get started. Oh, not quite. I'm pumping the brakes. We'll give it another minute. I can't. 25. Your member ratio. I have to green up here, Mike. Yeah. Morning. Morning, everyone. Morning.
Morning.
We have a lot of call-in users, so we're going to go ahead and try to call to order and do roll call a quorum, and then we'll reassess once we've done that. So this is Gail Bradley. Thank you, everyone, for calling in and participating remotely. We're going to go ahead and call to order the State Trauma Advisory Board meeting at 9:02 a.m. Roll call, please.
All right. Shelley Bissell. Andrew Tang, are you on the call? Brent Burgett, are you on the call? Chris Salvino?
He's here.
Chris Salvino?
I want to hear you.
I'm here. Can you hear me?
Oh, yes, sir. Cliff Jones?
Thank you.
David Notrica?
I'm here. Can you hear me?
Yes.
Yes? Okay.
Debbie Johnston?
Yes, Debbie Johnston is here.
Thank you. Franco Castro-Marin?
I'm here.
Art Gamer?
Present. Can you hear me?
Yes. Thank you. Herman Butler? Ayman Pfizerbound? Jeff Farkas? Judy Baum?
Yes, this is Judy.
Thank you, Judy. Melissa Anderson?
She's trying to get on right now.
Hey, this is Melissa in Tucson.
Great, thank you.
Hi, Sharon McDonough in Tucson.
All right. Neil Williamson?
Present.
Narav Patel? Philip Johnson? Rodney Reed?
I'm here.
Thank you. Sandy Nygaard,
I'm here.
Sean Boker,
I'm here.
Sarah Johnson,
I'm here.
and Vicki Bennett.
Present.
Cliff Jones.
Thank you, Cliff. We have quorum. We have 14.
And this is Andy Tang from Tucson.
Oh, perfect.
Costello from Havasu.
Sarah, can you say your name again there? We didn't hear that last one.
Danielle Stello from Havasu.
All right. We do have quorum.
Okay, we have quorum. Thank you very much.
Don't forget Mesa.
So hopefully everyone has the attendance packet that was sent out by Shelley. Just per reminder, per board bylaws, members missing 2 consecutive meetings will be getting an inquiry from the Bureau as to whether you're still interested in serving. If your phone number or email has changed, please send those details to Shelley so she can make sure that it's up to date. For vacancy, we have 1 vacant position right now. We are still looking for a representative for a federal Indian Health Services organization. The Director of Department of Health has reappointed a 3-year term for Judy Baum and Cliff Jones, so thank you both for reapplying and for signing up for another 3-year term. We are going to go ahead and mute everyone now, just so we can try to stop the background noise. And I believe the way, Shelley, if you can clarify that if you have any questions, that you can unmute yourself to ask questions. Is that correct, Shelley? Okay. Okay, so please, if you're not speaking, make sure that you have your phone on mute or your computer on mute. All right, we are going to move on to the Bureau report.
Good morning, Dr. Bradley. This is Terry Mullins. Are you able to hear me okay?
Yes, thanks, Terry.
I actually have a couple of different opportunities on the agenda today to speak about COVID-19. So right now, I'll give just a very short update that you may also want to add some comment to. The Bureau has been providing a number of different support functions for the state's Health Emergency Operations Center that are mostly kind of background activities. We have been working with the epidemiology side of the house to provide COVID positive address information to first response organizations around the state, and we do that primarily through arrangements with the state PSAP groups, and that information, while imperfect, has been uploaded into many PSAPs in a way that is consistent with the executive order that the data must be limited to 14 days worth of data at any particular time. We've also been providing guidance as the Department of Health has developed protocols for testing and also for the return to work guidance that I think is key to many of the operations of EMS agencies and healthcare organizations. And we are also kind of working behind the scenes to identify EMS agencies or facilities that have experienced acute shortages of PPE, and working then with county health departments to see if we can address those acute shortages. Although we're finally, and I hope most of you are also experiencing this, seeing some opening up of the markets for PPE. So perhaps we're entering into a little bit easier period of time. And then the final thing that I'll give an update on relates to a sense that there has been a significant decline in public accessing emergency care for chronic disease and time-sensitive illness and injury. And so we have been working with the public information officer here at ADHS to come up with a methodology to do some messaging about that. And that's a process that we hope will work out sometime over the next week to 10 days. And I'll stop there with the COVID-19 update. Dr. Bradley, if there's anything you wanted to add to that as well.
No, I just wanted to thank everyone across the state for kind of all of your flexibility. I know this has been pretty trying last 3 months, and especially with, as things keep changing, we appreciate your flexibility as we've sent out communication only to find out within 24 hours that recommendations have changed, and we then have to update those recommendations. So we do really appreciate everyone's patience and being willing to be so flexible as we move forward with everything COVID related. I did want to make one plug. We have Julia in the room here who's been helping with the HOC with Battelle, which is setting up an option for N95. So whether it's a hospital, clinic, EMS agency, fire department, anyone who is interested in signing up for Battelle, which is a free service to essentially get your N95s disinfected and back to your agency. So if you have any questions about that or are interested, that did go out via our Gov delivery, but we also have that information on our webpage as well under the COVID-specific page.
Dr. Bradley, if there's no questions in the group, I'll just go ahead and give my rules update right now, if that's appropriate.
That's great. Thank you, Terry.
If you refer to your packet, attachment 4B is the table that we've been using over the past 6 months to kind of keep people apprised of the several different rule activities that are being undertaken. We had a 2-month hiatus as the department spent most of its time and energy preparing for COVID-19. But 2 weeks ago, we began some internal meetings again to move the Article 7 area ambulance service licensing and Article 8 area ambulance registration rules forward. We anticipate posting a set of final rules in May, although it may slip into June, but we're going to try hard to get it out this month. And then importantly, we want to ensure that before the next legislative session, we have a good, strong draft of the Article 9 rules available for the stakeholder community. So we are working hard internally to use the feedback that we received from a very, very, very broad set of stakeholders in our first 2 solicitations late last year, and we anticipate getting out a first draft of the rules in July. And so that's our target, and then we'll begin a robust series of stakeholder meetings to go from that straw man first draft that is based on stakeholder comments and department notes into near final rules before the legislative session starts, and then moving forward. Yes.
Yeah, this is Dr. Phil Johnson from Summit. I've got a COVID question. I see COVID patients every day in the ER. And it takes me 2 to 4 days to get a result. So I'm admitting him on a presumption, and we don't know what happens until quite a few days out. Is there any hope that we can get a test that we can? I'm planning on flying to Vienna to see my fiance, and when I enter the airport, I get a COVID test, and the results come back in 2 hours. Is there any hope that in the USA that I can actually get a test that I can see the results in reasonable time?
I think that we're all probably hoping for that, but I don't want to give you a specific answer, doctor, simply because that's not my area of expertise. I'm willing to carry that forward and get a formal response for you if you want, but I think that everybody is working towards that ultimately.
Well, we certainly need it, and it's paramount that we get it because we're now months into this, and we're making very difficult clinical decisions with very little data.
And I understand that, and we certainly appreciate the fact that this has been a challenging time to provide clinical care.
Okay, well, I appreciate you looking into that.
I will. Any questions on the department's COVID activities or on the regulatory activities moving forward that I can answer at this time?
Sorry, we're going to interrupt you quickly. I don't know if someone's asking a question or if that's background noise. We can't hear you clearly.
What I'll do is I'll go ahead and go on mute Dr. Bradley, and if the question gets typed in, I'll be happy to answer it. Thanks everybody for your time.
All right, thank you very much. Next up, Ben, for service section update.
Good morning. Are you able to hear me okay?
Maybe a little further from the mic.
Further from the mic. Can you hear me okay now?
Yes, that's better. Thank you.
Okay. I have about 5 things that are all non-COVID related. Right now we have about 5 dashboards that are in the works. We're waiting for our IT department to get them updated and placed on the website. We have added an additional year of data to our trauma dashboard that this group has previously seen. Our hope is to add additional years to that dashboard, so you'll be able to see each year as we add it to the public-facing dashboard, in addition to a falls dashboard, motor vehicle trauma data dashboard, and an EMS dashboard. During our quarantine period, we have gone a little dashboard crazy, but we hope it provides useful information that this group will be able to see, and over the next year, we'll be able to kind of decide what dashboards we want to make. The trauma registry to AZ peers linkage is finally done. I know this group has been listening to us talk about it for quite some time. It is moving from our development environment to the production environment over the weekend when volumes are low. And then Mary Benkert will be making an instructional pamphlet for the trauma registrars about how to actually use it and what it does. I have to thank this group for their patience. I know we've been talking about getting this linkage completed for quite some time. It was completed quite a while ago, and we needed to do some testing. So I know that's something you've listened to us talk about getting done for quite a while, and we're pretty happy it is finally actually complete. The other non-COVID related update is we are entering the final year of our first responder naloxone grant. We have lots of naloxone, and I know that a lot of first responder agencies, naloxone is expiring. If you or if you're a base hospital, if agency you provide medications for, if their naloxone is expiring, please reach out to us. We do have funds to provide intranasal naloxone. It's only the intranasal naloxone for those agencies. We also have training available, and we have moved it to remote training. We know that was kind of a concern a lot of agencies had, especially rural agencies, was how would they be able to conduct training right now. We do have the ability to do some remote naloxone training. And then along with that, please remember to continue to report suspected opioid overdose cases. Obviously, this is something that's going to be of significant interest in the months to come. Will be what happened with suspected opioid overdose cases during the pandemic. And so please remember to continue to report suspected overdose cases during this period while we're all focused on COVID things. And then finally, my perennial plug to sign up for Gov Delivery. If you have not gotten a Bureau Gov Delivery or don't know what those are, you can sign up on the ADHS website. We learned there were some hiccups with our Gov Delivery sign up process. So if you have not seen a Bureau Gov Delivery or don't know what we're talking about, please reach out to either Shelley or you can find it on the ADHS contact page. We're happy to help you get signed up for those. That's the way we have to communicate all this information out to our stakeholders. So we're just trying to make sure that everybody gets signed up for those. And unless I've forgotten anything, that is all I have.
Thank you very much, Ben. Does anyone have any questions for Ben regarding what he brought up?
Hi, I do. This is Sharon in Tucson. On the available Narcan, who's the contact person?
That is a good question. So we are going to make our website a little more friendly to be azdhs.gov/naloxone. And I'll type that into the chat box. And there will just be, we're going to split it in half because we've got really good stakeholder feedback that it was impossible to find. And there will be a side for lay people and the public, and then a side for law enforcement and EMS. And so you would just click on law enforcement and EMS, and it will take you to our first responders link. And if you can't find that, please email me, because that's a bad sign and it means we haven't made it user-friendly enough and we need to adjust that as well.
Okay, thank you.
Any other questions for Ben? All right, excellent. We will move on to our standing committee reports. First up is, oh, I'm sorry, I skipped right past the cactus data report. My apologies there. All right. This is not an action item for this committee meeting, but we wanted to at least just bring this forward for this group in case anyone had any comments. This will be an action item for vote at EMS Council. So just to give a brief summary of the cactus report, the cactus data report is a data completion report. This has been in process for the last several years with some fine tuning and also working through some IT issues. So the first 2 quarters of 2019, so the first half of the year was run, that data completion standard was taken through EMSRUG and then to TEPI with a recommendation of a data completion standard to be met to maintain premier EMS agency status. So that was the recommendation that TEPI was going to make towards EMS Council. Between those 2 meetings, so between TEPI occurring in March and this meeting today, we're able to run the 3rd and 4th quarter reports for 2019. And what we noted between the first and second half of the year was there was some drop off in the data completion in the second half of the year. The reason we bring this forward is the recommendation for completion standards that TEPI made or is going to make towards EMS Council is going to be affected a little bit because essentially now the bar to meet is a little bit higher with the second half of the year for 2019. We wanted to just bring this forward to all 3 statutory committees. This did go out to everyone just to get a little bit of review, but just to make sure that people are aware, we are trying to fine tune this and better the process. But we did recognize that especially for smaller agencies or agencies that may not have as many incidences of incidents of illness and injury, that there may be situations where you have a drop off in your data completion standard. That is a little bit of background on the cactus data report. I don't know if anyone had any time to review that or review the recommended standards and had any questions or comments.
Hi, this is Sharon in Tucson. I do have a few questions. I am new to the EMS Council, and I did send these to Dr. Bradley yesterday, and she asked that I bring them forward here because there may be others who have the same question. I'm wondering, what is the purpose of the cactus data collection, and what does it provide that the Arizona Peers data does not? In essence, what's the purpose or intended use of the data aside from, yes, you completed the report? What are we using it for?
I think Ben,
Yeah, so this
Gonna
has
handle
been, so, so I guess I'll rewind a little bit and go into some of the history of kind of how we got here. So about 2 years ago, my group started to do, my group is tasked with doing performance improvement and quality assurance for the state. And when we started looking at what we wanted to do for performance improvement, we realized that we couldn't really start doing performance improvement because the data quality was so poor. And so when we looked at the tools available to us for performance improvement, the tools that were available were all kind of came with some disadvantages. So one of the options that was available to us was essentially making a tool from scratch. So it comes with some disadvantages. The other option was to essentially use the validation score that I think a lot of the agencies are probably familiar with. That also comes with some disadvantages. This is sort of at the agency level, allows an agency to determine where their for time-sensitive injuries and illnesses, and then for the things that would essentially, for those core data elements that would make a record break for us, how complete are those data elements? I think kind of the downside is because this is done at the agency level, there's no immediate feedback to the paramedics. So the trade-off with doing this at the validation score instead of at the agency level is at a validation score rule, the paramedic, when they go to upload their report, sees an error and it says you didn't fill out a patient date of birth. And we'll have more of this discussion, I think, at kind of this granular level at EMS Council. Whereas the EMS or the Cactus rules, by the time that feedback gets delivered, because this report is delivered to the quality assurance officer or an EMS captain or someone like that, the implementation is done at sort of the organizational level. And so that immediate feedback may not be delivered to an individual. So, so yes, so there are trade-offs. What the trade-off allows us to do is customize it. So we were able to make this report from scratch. And so Vatsal and her team were able to really customize this. And with Dr. Bradley's help, we were able to go through and do things that the validation score and the software vendors weren't able to do. And so we were able to sit there with a list of conditional logic and ICD-10 codes and individual data elements and really come up with what our stakeholders think is useful information.
Okay, so are there, and forgive me guys, I'm just trying to get my mind wrapped around it so I can explain it to my leadership group. What makes it different? I mean, so the intent is to give a more immediate feedback to the providers. Did I get that right? So that I can well assess what my agency is or is not well completing, and I can give an immediate feedback to make sure it happens. Did I catch the gist correctly?
Yes, I think for this report, I think that falls to no. I mean, I think it would be hard for this report to go. Actually, let me rephrase that. Yes, you could give this report to an individual provider, to an individual paramedic, and they could see that their, aspirin prior to arrival completion rate was very low, and then hopefully improve that.
Okay.
Yeah.
So then from the peer side, I mean, I feel like most of this is captured there.
They overlap, so it's not separate. We've taken we've kind of cherry picked some data elements within AZ peers. So I guess if you were to draw circles, they get kind of smaller, and cactus is the smallest circle within AZ peers. So AZ peers is a little bit bigger, and then within AZ peers, we've just kind of cherry picked some data elements we think are the most important within AZ peers for performance improvement.
So it's no additional information?
Correct. It's smaller than AZ peers.
Okay, and I noticed when I looked down, okay, just for a little small piece of information that I noticed in there, and I would love to hear what the group thinks on this. I could see that the race indicator is one of the lowest numbers of adherence. Correct?
Yes, I'll just chime in. I know race in particular for the Bureau has always kind of been a tough one for us. I know other bureaus within the Department of Health use this indicator to guide things. It's been, I mean, I'm a paramedic, I get it. It's very difficult to collect. It's something that's uncomfortable to ask people about.
I think politically it's even frowned upon, certainly in our community. So I think that's a tough one. And are there any associated present or forthcoming repercussions of requiring data sets? Is there an if-then with this data set that says, if you don't do it, then here's what happens, that causes us to be in conflict with our own community politics departments?
So within the community, yes, that I can't speak specific to that. So that is entirely possible. Our hope is we would never put you in a position where we are asking you to collect something that you would not, you know, your community has told you don't collect, and then we're asking you to collect. What we have tried to design is a process where there is a year of stakeholder feedback, so that if that were the case, that data element could be removed with stakeholder feedback, and you could come to the group and say, look, this is something that is contentious, we think it needs to be removed, or we think will lead to, I can tell you my personal fear is it will just drive bad data quality. So people will just enter data to meet the completion standard and say, we've entered something to make me go away, but really you're just filling in a field. So if that were the case, I would say, you know, please bring us that feedback so that we can remove the data field from this data set. Yeah.
That helps me. Thank you.
Thank you for the discussion. Any other questions or comments before we move on to the standing committee reports?
Gail, this Scars Gamer, could you, or Shelley, could you scroll down a little bit to those tables where there was basically no meeting of the threshold, or the percentage reported in certain of the quarters, a little further.
Are you talking about the very last page, Garth?
Yeah, getting toward that, like right there, and from there on. You know, my question is, there's not a lot of meeting of the threshold for these data elements, and I know this represents an aggregate from across the state, but with so many no's in the standards met column, is anybody meeting the standards to maintain premier agency status? Because this is tied to premier agency status, isn't it?
So that is part of the conversation we're going to have at EMS Council in a little bit.
Well, I'll save it till then. There'll be some opinions rendered on this.
Yeah. So yeah.
Understood. Thank you.
Dr. Bradley, this is
Conversation.
Terry. Can I just add one piece of information?
Yes, please, Terry.
I just want to just reiterate that this is an aggregate report that we create to assist in benchmarking, but every agency that would be part of the Premier EMS Agency Program or is recognized as a Premier EMS Agency Program would get a similar report that shows their results against, so that they can compare themselves against the state aggregate. That's kind of how we envision this being of use to the individual agencies.
Yeah, that's a good point. Thank you, Terry. So each agency would get their own report, and then this is just the statewide one to compare it against. Obviously, we don't want to show an agency's individual report, but each agency would get their own report to compare against the state aggregate.
Thank you for those bits of information. Appreciate your candor on this.
All right. We will move on to the standing committee reports. First up is the Trauma and EMS Performance Improvement Standing Committee. Sean?
Good morning. So TEPI met on March 19th, and the bulk of the discussion centered around the Cactus data set. We made several recommendations that are subsequently going to be forwarded on to EMS Council. Some of them were with regard to the order of the list, and then also some recommendations around completion thresholds. Again, this will be discussed. I think that's all I have.
Sorry, Sean, you cut out there. Are you finished with your report?
Yes, sorry, I was having
Okay.
some technical
All right.
difficulties.
Not a problem. Understandable. Thank you. Next up is Education Standing Committee. Sandy?
Yes, good morning. We also met on March the 19th through a teleconference. And our discussions, Dr. Rice wanted us to review the list for the training modules. And so several of our committee members volunteered to update and review those models and submit them back to Dr. Rice for compilation, and they'll be brought back to the committee in July. Our ED bylaws are due for review, so we were to submit submissions, any revisions to Dr. Rice or to the Bureau. Discussion and action items, we discussed amend and approve the updated what should go into the EPCR training. Brian discussed that, made the motion to discuss that, and we had some background on the updates, and the updated training was approved. I think that's pretty much the majority of what happened, unless Dr. Bradley, you have anything to add?
Nope, that's great. Thank you, Sandy.
Thank you.
All right, next up is PMD report. Franco?
Yeah, can you guys hear me okay? Hello?
Yes, go ahead.
All right, so we met, let's see, the date at the last meeting was March 19th. On the chairman's report, one key discussion was that the PMD bylaws are due for review. The Bureau report, we had a report from Julia from the EMS for Children, working on a safe sleep education module. With regard to agenda items, We discussed and approved the drug profiles with several minor clarity changes made along the way. The question of dopamine or the dopamine entry was specifically tabled. We discussed adding high-flow nasal cannula to the paramedic scope of practice, but that was felt to fall under non-invasive positive pressure ventilation and deemed already within the scope of practice. So that was basically tabled. We discussed and approved making dopamine and norepinephrine optional agents. We removed several items from the Table 1 drug table, including activated charcoal, nalmefene, verapamil, vasopressin. We discussed removal of oxytocin, but that was a failed motion. And then we discussed, amended, and approved the treat and refer T3Gs as well. And that's it for my report. Thank you.
Thank you very much. Next up, Kara for Trauma Managers Workgroup Update.
Hi, this is Kara Mitchell for the Trauma Program Manager Work Group. We had to cancel our March 23rd meeting, but we are on track to meet via WebEx June 19th. We're looking to discuss best practices and lessons learned through all of the COVID stuff that has gone through. There's been a lot of discussion across the country from other TPMs about best practices for trauma centers. So we're going to discuss that at our upcoming meeting.
Thank you. Next up, Julia for PACES report.
Good morning. So we also met last on March 19th. We discussed the Safe Sleep education project, which has been somewhat temporarily placed on hold, but we'll be back and working on that soon. The National EMS for Children data collection for EMS agencies wrapped up in March, and so we had a little bit over 100 EMS agencies participate in that, so we should have the results back from that from NADARC soon. The National Pediatric Readiness Assessment, which was previously scheduled for June, has been postponed, so that will be a future project. And then we're also just in discussion on what kinds of projects the group can tackle in the future as a group. That's it.
Thank you, Julia. Next for discussion on action items, can I have a motion to approve the minutes?
So moved.
And if you can, sorry, if you can.
Second.
Can we get the names for the first and the second, please?
Garth Gamer. Sorry.
Thank you, Garth.
Nutrika.
Any amendments needed to the minutes? All right. Hearing no amendments, all those in favor of passing the minutes as projected?
Aye.
Aye.
Any opposed? All right, hearing no opposition, the minutes are approved. Thank you very much. Next item, we're going to discuss some regulatory impact of COVID-19. If Chief Mullins is on the line, we have a number of items we wanted to discuss, really specific to COVID-19 as it relates to trauma. We recognize that COVID-19 has affected kind of all aspects of EMS and medical care and has had a significant impact on trauma as well. At the Bureau of EMS and Trauma System, we've been kind of talking about this and wanted to bring it up at this forum to just discuss the different pieces. So, Terry, I'll go ahead and hand over to you.
Thank you, Dr. Bradley. Looking for a document in the background as I speak. One of the goals that the Bureau had as we recognized that COVID-19 was going to have could have or would have a significant impact on healthcare operations in Arizona was to position the Bureau in a way that we were helpful to healthcare providers as opposed to kind of focusing on regulatory issues. And so we've used that framework with all of our regulated entities. The trauma care community is slightly different because the American College of Surgeons plays a very large role in how many of your facilities are permitted to operate within the state system. But there are other areas, including other than the American College of Surgeons, that we anticipate are going to be issues that all of the other trauma centers have to, that we're all going to have to deal with as we move forward with trauma, with COVID-19. We don't have any preliminary data yet, but we just anecdotally, it seems likely that there will be, or could be, a change in the amount of money that is available for the Indian Gaming Fund for trauma care that most emergency departments in the state receive and all level 1 trauma centers receive. We also recognize that there has been a significant decrease in volume for trauma calls. And so the trauma volume requirements for level 1 facilities may require some additional thought and communication with our communities, even though we were able to create 3 separate methodologies for facilities to meet trauma volume. And we also have seen over the past 3 years a gradual decrease in funding that comes from motor vehicle fines that goes into the EMS operating fund. And we anticipate that there may be a not insignificant decrease in the EMS operating fund this next budget year based on the change in driving habits over the past 3 months as the state has been on work from home for most folks and stay at home. Another area that we anticipate will be important for us to evaluate moving forward is the role of telemedicine in trauma care. And this is an area that I know several of you have expressed a lot of interest in, seeing if we could move into the regulatory realm a little bit more closely for the trauma centers. And so I think that's an area that's going to need a lot of discussion. And then we're going to have to come up with a methodology mostly for those facilities that are state designated and ACS verified, those combination centers, with the ACS issuing the additional year of verification time for those facilities that are ACS verified. There's now a change in the designation period for the state designation as compared to the ACS verification. I don't have any specific points that I want to cover today, but I would like to open the floor, if I could, to just solicit information from you all of areas that you think the department will need to consider as we continue down this pathway with COVID-19 and looking for alternate ways to make certain that we keep our trauma system strong. So I'm going to go ahead and stop talking there, and I'll listen and take notes for any comments that you guys have for us.
Thank you, Terry. Any questions or comments from the group, please, just a reminder, unmute yourself so we can hear you if you have any questions or concerns. We anticipated quite a bit of discussion amongst these items. All right, hearing no discussion points, we will go ahead and move on to the last action item. We need to discuss and approve creation of a bylaws update work group. We are due for bylaws updates this year. In the past, historically, we have brought representatives from the 3 statutory committees together to do one bylaw update to make sure that they kind of have the same standards across the 3 different statutory committees. So we just wanted to get approval to go ahead and create a work group to establish updates to the bylaws for STAB. Can I get a motion to establish the work group?
Hi, this is Rod Reed. I'm making a motion.
Thank you, Rod.
Doris Gamer, second.
Sandy will approve.
Sorry, who is the second?
Doris Gamer.
Thanks, Garth. Is there anyone that would like to participate in the work group? If you'd like as well, you can always send us a message in the chat function, or you can also send Shelley an email and we'll get you recorded in the work group. So, technically, we do need to vote. All those in favor of forming a work group to update the bylaws, please say aye.
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 Aye. Thank you. Any opposed? That was potentially one opposed, but I think it was just car noise.
Hi, this is Sharon. I'm happy to be on the committee.
Thank you very much. All right, we've got one volunteer down. Thank you.
And there's a note from Franco. He's having he's unable to unmute himself.
This is Kara Mitchell. I would be willing to volunteer for the committee.
Thank you. We got Garth, Kara, and Sharon. Is that correct? Sean Boker as well. Okay. All right. If anyone else is interested in participating, please feel free to email Shelley, and she'll make sure that you are included in the update. So we, next for agenda items to be considered for the next meeting, we initially were going to have some other items that we were going to start working on with STAB between the meeting in January and today's meeting. Then COVID hit and everything just got a little bit redirected towards that. So certainly if there are any agenda items that you'd like to be considered for the next meeting, please email those to either Shelley or myself, and we will make sure that we work on those. We are also up to kind of any thoughts from this group in terms of what you would like to see coming from STAB. Any kind of products or ideas. So definitely, if you have anything, please feel free to bring it up now, or you can let us know via email as well.
Hey, it's Chris Salvino. Can you hear me?
Yes, Chris, thank you.
Hi. This is somewhat indirectly related, but is there a possibility that you guys can consider talking to the governor's work group about COVID-related instructions to restaurants and movie theaters? Because unless we get our handle around this, trauma will be indirectly affected, because I was in a restaurant last night. No one's in masks. No one had gloves on. They were wiping down tables. So it's hodgepodge. You go to a drive-through, everybody's in masks. So there's been no consensus from the state on how these different outlets are supposed to be conducting themselves. And that's going to affect, especially since this is a tourist state, what kind of trauma comes in here.
Thank you, Chris. We can definitely forward that message along.
Yeah, this is
Dr. agrees with that, but
Johnson.
it's a disaster right now, and it's going to be a horrible problem in the state when all the snowbirds come back. And you walk into a restaurant, everybody's next to each other, and there's no gloves, there's nothing. It's starting to break down.
I would second that issue. It's huge.
In fact, maybe there's something this group could do, because we happen to be medical experts. I don't believe the governor's office is. We pretty much know what's going to happen with this virus. So I don't know how they're being advised or what's taking place, but otherwise they're going to be picking up the pieces with the entire trauma centers inundated by the fall.
Certainly, we can get that information over to the HEOC. So the HEOC is the Health Emergency Operations Center that is run by the Department of Health Services, and they are in charge of most of the guidance that has come out regarding what to do in terms of infection control. But if there's questions or concerns, certainly we can pass that message on to them.
Maybe there could even be a motion from this group if you support that, because I haven't seen any guidance. I'm not sure if anybody else has that would make me feel comfortable to go out to, even at the grocery stores, it's not being consistent. So I don't know if anybody knows what the guidance has been. Maybe it's just people not paying attention to it, but it's just, we're going to be swamped this winter.
So there is a coronavirus website through ADHS. Have you seen that, Chris? Because that does have a number of resources, including guidance from multiple different entities, anywhere from healthcare facilities to doctor's offices to gyms, movie theaters, restaurants. All of those guidance documents are on the website.
Sure, but maybe they need to go one step further and attach that to a licensure, because if they're not going to follow it, it's just guidance, that's a problem. That's my 2 cents. You know, you can make a decision not to go to a restaurant, but the people that are going there are going to be in a car accident. They're going to end up in your trauma center.
I agree with Chris. That's a big deal.
This is David Tricka. It's interesting too that, you know, we in Phoenix we have a tendency to think that what's going on in Phoenix is what's going on in Arizona. And I think that they give you a perspective from outside of the urban centers.
No, thanks for letting me express that. I'm not sure if we could do anything about it, but I think, again, it indirectly is going to affect what's going to happen starting in the fall through the winter in this state.
Dr. Sabino, this is Kerry. We'll make certain that we carry that message forward.
Dr. Bradley?
Yes, go ahead.
This is Garth Gamer. Possible agenda item for next meeting might be in view of, there's a lot of things that got tabled, a lot of potential projects that got tabled by COVID, and I think that one of the things that we ought to talk about is pilot projects and laying down some standards on potential pilot projects for exploration. Personally, I work with Phoenix Fire, obviously, and we were looking at the San Antonio project using low titer O negative or O positive blood in trauma resuscitations, and the COVID hit and we kind of tabled that, but we were thinking about coming forth with a pilot project, and we're talking about what sort of attributes for such a project the Bureau would like to see, and maybe that would be an item for discussion. I can think of other targets for study, such as antibiotics in the field for open fractures, TXA, any number of things that might come across our radar screen. Back to the previous agenda item, and I know that there was a dearth of discussion after Terry got done, but everybody's kind of in a state of shock. I think everybody wants to see kind of what is going to happen with the EMS operating fund. Is there going to be, what are the preliminary figures going to show on a potential decrease? And then once you see potential figures, then maybe there can be some reaction. Likewise with trauma volume thresholds, everybody is kind of in a wait and see mode. But I think from my point of view, I'm very happy that you folks brought up these potential headwinds in our future. That's all I have to say.
Thanks, Garth. I think we can certainly work on kind of bringing forward the language of what's required. I believe that's in rule or statute. I'll get clarification on that. But we can certainly bring that forward so it's a very clear-cut process so everyone knows across the state if they would like to initiate a pilot process, what's involved with that. So thank you for requesting that. I think that's a great idea. All right, next up is call to the public.
Dr. Bradley, it's me again. I want to go on record as saying that I personally am very grateful for the activities of you, Ben, Terry, during this whole crisis. Your responsiveness and your willingness to help out providers on the street, medical direction, pre-hospital environment, in-hospital preparations for receipt of COVID patients. I think you've been great and have provided meritorious service.
Thank you, Garth. I appreciate that. Next, summary of current events. I'm sure everyone's aware they have all been canceled due to COVID, so that is all on hold. As things do start coming back on board, we will certainly let the group know and make sure that's available. Our next meeting is September 17th, 2020 at 9 a.m. As we get closer to that date, we will have a better idea in terms of process. I think that we have certainly dialed in our ability to do online meetings. We really appreciate everyone participating online and via phone. And hopefully the audio worked okay that you were able to hear. So big thank you to everyone for participating remotely for today's meeting. If I can get a motion to adjourn, please.
Second. Motion.
All right. Excellent. Thank you, everyone. Have a good day.
Thanks. Bye-bye.
Thank you.
Thank you.
Thank you.